Alright, so let's get started. The kidneys play an important role in regulating the volume of water in the body along with electrolytes such as sodium, potassium, magnesium, calcium, and phosphorus. The kidneys also filter drugs and toxins from the body. They also help with blood pressure regulation, and although I won't be going into this topic, it's good to remember that they do help with red blood cell and strong bone production. For the physiology of the kidneys, I'm going to focus on 5 portions. These are the ones that are most important to me. So the first one is the glomerulus, the proximal tubule, the loop of Henle, the distal tubule, and the collecting duct. The glomerulus is going to be a low pressure space in which blood travels through. This is a site that removes waste products and eliminates poisonous substances from the blood. If there are traces of protein in the urine, this is a sign of kidney damage. So when we stage chronic kidney disease, CKD, we primarily use the glomerulus filtration rate and albumin to creatinine ratio. The afferent arterial is the high pressure space. Medications such as ibuprofen, non-steroidal anti-inflammatory NSAID, is commonly found over the counter and will cause constriction in the afferent arterial. This enters the glomerulus. Other medications besides NSAIDs like loop diuretics, aminoglycosides, cisplatin, tacrolimus, vancomycin, and radiographic contrast dye may cause drug-induced kidney disease. This contributes to morbidity and mortality. This is most commonly seen in a hospital setting. And as a reminder, acute kidney injury, AKI, is a temporary loss of kidney function and it may occur in patients with a history of kidney complications. The efferent arterial carries blood away from the glomerulus. Medications such as angiotensin-converting enzyme inhibitors or ACE inhibitors such as lisinopril, enalapril, and captopril will be used if the patient has high blood pressure. Also if they're diabetic, or if they have proteinuria or chronic kidney disease. A chronic kidney disease patient without proteinuria would have a blood pressure goal of no more than 140 over 90 millimeters of mercury, while a patient with proteinuria would have a blood pressure goal of 130 over 80 millimeters of mercury. We will expect the serum creatinine to increase but no more than 30% on a patient. So if it does increase past 30% after trying an ACE inhibitor and failed also with an angiotensin receptor blocker, then we refer them to a nephrologist. Adverse effects of ACE inhibitors are going to be dry hacking cough, angioedema, and we must make it a habit to counsel the patient on the risks of hyperkalemia. They must avoid high potassium supplements, and these high potassium supplements are normally in excessive amounts. Also, any salt substitutes. As a final important note, ACE inhibitors are renally protective. We are advised by the guidelines to maximize the dose for this protection. The proximal tubule is referring closest to the Bowman's capsule, the nephron. Approximately 2/3 of sodium and calcium reabsorption occurs in the proximal tubule. The medication acetazolamide, an inhibitor of the carbonic anhydrase enzyme, will result in reduction of hydrogen ion secretion at the renal tubule and an increased renal excretion of sodium, potassium, and bicarbonate. Adverse effects of acetazolamide are hyperkalemia and metabolic acidosis. So a good note to remember is that hyperkalemia may precipitate from metabolic acidosis, and vice versa, hypokalemia can precipitate from metabolic alkalosis. So more specifically, I'm going to talk about the ascending loop of Henle, which has an approximate 25% reabsorption in sodium and calcium. Loop diuretics such as furosemide inhibit the sodium, potassium, and chloride channel. There will also be an increase in secretion of calcium and magnesium. Furosemide may be used for patients with edema or congestive heart failure, but adverse effects to remember are going to be hypokalemia, low blood pressure, and gout. As I mentioned earlier, there is 25% reabsorption, so inhibiting this channel will increase the sodium in the urine, also potassium, and that's how we make the connection for hypokalemia. Distal convoluted tubule, which is furthest away from the nephron, will aid in the regulation of potassium, sodium, and calcium. Approximately 5% of sodium is reabsorbed at the distal convoluted tubule. Thiazide medications like hydrochlorothiazide inhibit the sodium and chloride pump, making it a weak diuretic. Long-term effects of these medications, thiazides, with patients are bone protective, seeing as how thiazides will increase calcium reabsorption. Thiazides are also useful in patients with edema, hypertension, and congestive heart failure. Adverse effects now of thiazides are going to be similar to those loop diuretics. So hypokalemia, low blood pressure, and gout. So why would there be gout? A plausible answer to this would be hyperuricemia, which is an abnormally high level of uric acid in the bloodstream. Lastly, the collecting duct. This is the fluid that has passed through the distal convoluted tubules and is drained into the collecting duct, and then the urine passes from the ureters into the bladder. Aldosterone receptor antagonists, such as spironolactone, work on the collecting duct, and the mechanism of action to focus on in a kidney-related question may be that they increase sodium excretion and potassium retention. Spironolactone may be used in hypertension, heart failure, and ischemic heart disease, which is also referred as coronary artery disease. This is mostly associated with atherosclerosis.